Good afternoon. I know it's late in the afternoon at this time, but I want to assure you that the last speaker of the day, Dr. Lerer, will essentially justify the fact that you have stayed to participate in his presentation. I'm privileged to introduce him this afternoon, firstly because we've known each other and worked together for, 26 years. When we first met, Dr. Lerer came to the Lafayette Clinic, where I was in Detroit, for a 2-year fellowship. And this little story will describe his attitude to his research activities. In the first year he was with us in the program, there is a prize known in the United States as the Bennett Research Award, given by the Society of Biological Psychiatry. And he wrote a paper and submitted the paper to the Society, and he received the second prize award, which is a worldwide competition. The thing that he did next year was he wrote a different research project and submitted that again to the Bennett Research Award Committee, and he got the first prize. So his ultimate thing was to continue doing the job in many different ways, and he often ends up being very successful. His current position, his professor and director of the Biological Psychiatry laboratories at the Hadassah Hospital at the Hebrew University, and his interests are fairly broad, and they include psychopharmacology, genetics, and pharmacogenetics of major psychiatric disorders, depression, and schizophrenia. There are other projects that he's very involved in, but rather than continue, I'll let him present his work himself. Dr. Lerer.
Well, thank you very much, Sam, for that very kind introduction. And of course, I owe it to you for encouraging me to submit for the first time for the Bennett Award, and then when I didn't make it to the top, to submit the second time. But you modestly omitted that part of it. I'm also very pleased to be here. I'm very honored to be invited to participate in this course by Professor Lesinio, who I have known for some time, since his period in Los Angeles. As far as his journal, Molecular Psychiatry, is concerned, I feel like the guy who bought shares in Microsoft when it was still in Bill Gates' garage, because we published papers, several papers over the years in molecular psychiatry, starting from when the impact factor was very low. And I watched our shares grow over the years, and now each share is worth 15 impact factor points. So that was a pretty good investment. I didn't buy shares in Microsoft at that stage, but then, of course, I hope I'm a better scientist than I am a businessman. I also am pleased to be here because I am a strong believer in the concept of translational science. I find from time to time that my interpretation, my definition of translational science differs somewhat from everybody else's, or from a lot of views, and I mentioned this approach when I participated in the discussion following the last talks. And I hope I'll be able to expand upon that a little in the course of this talk. Doing that, I want to discuss something which isn't related to my talk at all, except from the standpoint of it being related to translational science. It is related to our chairman today, Professor Gershon, awarded the Curtin Award yesterday for his work on lithium. But this, I think, these two papers up here are really an example of some of the finest translational work in psychiatry. At the time this work was done in 1975, there were some basic papers published relating to the role of serotonin in the mechanism of action of antidepressant drugs. And what Dr. Gershon and his collaborators did was to move the focus over to patients and to use a synthesis inhibitor of serotonin, and to demonstrate in these two papers, published in two separate journals, that both imipramine and the monoamine oxidase inhibitor tranylcypromine, that their efficacy in depression was dependent on availability of serotonin. This was a remarkable piece of work done already in 1975. Dennis Charney and the George Henninger and the Yale group went on to do similar work using serotonin synthesis inhibitors. So if one talks about translational science, I think this is a translational science. Should have been another slide. Yeah. Another study which I did, which addresses the issues in similar ways, was done in Detroit when I came in 1982 to work with Sam and his group. There had been work done previously which showed that lithium inhibits the temporary increase in mood that is induced by methylphenidate or by amphetamine in individuals with bipolar disorder, and also in some studies in non-clinical samples. And we did a study in which we looked in a similar design at whether carbamazepine, a drug which was then at the beginning of its use as a treatment for bipolar disorder, whether carbamazepine would also inhibit the effect of methylphenidate to enhance mood. And we found it did not. Now, this is a negative finding of considerable importance for those of you who were at the Curtin medal presentation yesterday, because one of the questions that Dr. Gershon was asked was, is there a difference in the clinical spectrum, and is there a difference in the mechanism of valproate, another anticonvulsant used to treat bipolar disorder and manic states, and lithium? And this would suggest that there is, that while carbamazepine is an effective anti-manic agent, as of course is lithium, lithium inhibits the manic state induced by amphetamine, whereas carbamazepine does not. So I think this is another important example of translational research. At any rate, today I'm going to take a different tack. In the years since 1982, my colleagues and I have gone with the molecular revolution in psychiatry, and I'm going to talk about molecular-related issues, and specifically I'm going to discuss antipsychotic drugs and the potential role of pharmacogenomics in predicting adverse effects of antipsychotic drugs. I'll start off to discuss a little about the clinical background of antipsychotic drugs. For those of you who may not all be psychiatrists, I think probably a lot of the people in the audience are not psychiatrists or not clinicians, so I'll explain a little bit about what psychosis is and about what antipsychotic drugs are. And then I'll talk about some work that we have done, particularly the gene RGS2 in antipsychotic-induced Parkinsonism. I'll present the clinical studies which led us to focus on this gene, and then some studies that we did in a confirmatory fashion in mouse model, translating from the clinical studies back to mice. I'll then go on to talk about a second gene in antipsychotic-induced Parkinsonism, ZFPM2. I'll present results from a genome-wide association study that we didn't do ourselves, but whose results we analyzed, and then a replication study in which we sought to find independent support for our finding. And finally, relating somewhat to the discussion following the previous talk, a previous series of talks, I'm going to talk about resistance to antipsychotic-induced Parkinsonism as a guide to choice of antipsychotic in clinical practice, And the translation of these findings, the potential, I hope, translation of these findings from man to mouse to clinical diagnosis. Just to point out or to disclose that my colleague Leo Greenbaum, my postdoc, and I hold patents for RGS2 and for ZFPM2, and so I think the audience needs to be aware of this fact when I talk about the work. So, what are antipsychotic drugs and what are the clinical indications for their use? Antipsychotic drugs are drugs used to treat psychosis. Psychosis is most parsimoniously defined as a defect in reality testing. Reality testing, which is needed for us to act and to behave and to think and to perceive in a fashion which is consistent with reality. So individuals who have a defect in reality testing are psychotic. They may have hallucinations, they may have delusions, they may behave in a totally bizarre fashion. Psychosis is not the same as schizophrenia. Patients with mania may be psychotic. Patients with organic mental illnesses may be psychotic. And patients with depression may be psychotic. Antipsychotic drugs are not anti-schizophrenic drugs, even though there is a tendency to see them that way. So there is a wide spectrum of indications for antipsychotic drugs, but clearly the most important use, the use which has the greatest impact of all, has been in schizophrenia. And of course, the antipsychotic drugs, since their introduction in the 1950s, soon after lithium was introduced, have brought about a complete revolution in mental health. They've entirely changed the face of mental health, led to a reduction of about 80% in occupancy of beds in psychiatric hospitals, led to the closure of many psychiatric hospitals, and had some bad results, led to the premature closure of many psychiatric hospitals, but that's not our topic today. A second issue in the background I'd like to discuss are what are the key advantages and disadvantages of antipsychotic drugs. The advantages are, of course, that they work, that they've had this enormous impact on mental health. They are, of course, effective in the acute psychotic state. They're considerably less effective in the chronic state. They work on so-called positive symptoms, delusions, hallucinations. They work much less on the inability of the patient with schizophrenia to adjust to normal life and to return to normal functioning. I think a third issue to be discussed is the difference between typical and atypical antipsychotics. This is a term that is used very often. Typical antipsychotics are often called first generation and atypical second generation. What is the difference between them? The difference, of course, there are significant differences at the pharmacological level in that while both bind to dopamine receptors, the profile of atypical antipsychotics involves a greater degree of binding to receptors other than dopamine, particularly serotonergic receptors. And there are important clinical differences, which I'll discuss in a few minutes. And finally, what are the key considerations in choosing which antipsychotic drug of which generation to administer? I think this is a critical issue. There are a lot of drugs out there. Some of them induce serious adverse effects. All induce serious adverse effects, but not all of them induce the same serious adverse effects. All are equally efficacious, except for one, clozapine. And I think it's important to consider how one chooses these drugs and what pharmacogenomic research can do to help us make this difficult choice. So, looking then at some core principles, I mentioned earlier that all effective antipsychotic drugs are dopamine D2 receptor blockers. That is a catechism which was true until a short while ago, was not true for a short while when a glutamate-acting drug appeared to be effective, and is now true again. There is no antipsychotic drug which does not block dopamine D2 receptors. It's intriguing, it's fascinating, but it's the truth. The second thing is that all effective antipsychotic drugs induce extrapyramidal symptoms and tardive dyskinesia. Extrapyramidal symptoms include akathisia antipsychotic-induced Parkinsonism, and TD, tardive dyskinesia, and all induce weight gain, hyperlipidemia, and diabetes, as well as affecting QT interval. The difference between first and second generation antipsychotics is the extent to which they have these effects. First generation drugs induce to a much greater extent extrapyramidal symptoms and tardive dyskinesia. Second generation drugs do induce these effects, but their effects on weight gain, hyperlipidemia, and diabetes are much more striking. So as I mentioned earlier, there are 15 to 20 antipsychotic drugs available, varies between countries. How does one choose which drug to administer? Efficacy. Can one use efficacy? It would be nice to be able to choose a drug which is going to be better for a particular patient. There is no drug which is better than any other antipsychotic drug, with the exception of clozapine. There is no doubt that clozapine is effective in patients who have not responded to other antipsychotic drugs. But taking into account certain findings that did emerge from the Catie study and from other studies which suggest that in certain circumstances maybe olanzapine is slightly better, I think it's generally true that one cannot choose an antipsychotic drug on the basis of efficacy. Ancillary effects are quite important. Some drugs are sedative, some drugs increase weight significantly, others like ziprasidone are associated with weight loss. So that can certainly guide us. Potency. One wants to have potent drugs, but when one uses first-generation antipsychotics, the price that one pays is side effects. The more potent the antipsychotic drug, the more severe are the extrapyramidal symptoms. Adverse effects, I'm going to talk considerably more about this, but clearly we would like to be able to choose the drug on the basis of which adverse effects the patient is likely to suffer. But at the moment, there's no clinically applicable way to predict. Cost is a major consideration. The second-generation drugs are expensive. Most of them are still on patent, and they cost a lot of money. They cost health systems a lot of money. Affluent countries can afford them. Countries which are not affluent cannot. And this is a very significant issue and will certainly continue to be one for some time. And finally, personalization, the holy grail that we're talking about, being able to choose the drug in order to adapt it, in order to have it precisely tailored for the genetic profile of the patient that we are currently treating. I just want to repeat again the issues about the adverse effects of the two types of antipsychotics, because it's very relevant to what I'm going to talk about. First generation antipsychotics primarily are the ones that induce EPS, extrapyramidal symptoms, and these include akathisia, Parkinsonism, TD, and neuroleptic malignant syndrome. Second generation antipsychotics, their primary issue is metabolic adverse effects. Weight gain, hyperlipidemia, diabetes, and also effects on QT interval. So, since first-generation antipsychotics are widely used worldwide, especially where cost is a major consideration, and since there is increasing appreciation of the potentially serious adverse effect of second-generation antipsychotics, it would be really useful to have a test which could allow us to predict which patients are going to develop AIP or EPS and which patients are going to develop metabolic effects. And there was a time when I would give this talk to psychiatrists and they would sort of roll their eyes and say, well, what does this guy want? The second generation drugs are here. They were not aware at the time of the issues relating to the metabolic syndrome induced by these drugs. And they were well aware that the old drugs induced severe extrapyramidal symptoms. Now, the playing field has been leveled. We're in a situation where the adverse effects of the two groups are clear, and one clearly needs a way in which to choose between them. What strategies can we use? Pharmacokinetic factors, genetic polymorphisms that influence availability of the drug. We had two excellent talks about this matter earlier on, and I will not expand about it now. And secondly, pharmacodynamic factors. genetic factors that influence the site of action of the drug, the transporter to which the drug binds, the receptor to which the drug binds, the enzymes which affect the availability of the drug. These are two directions, two areas which I think are critical in designing studies that will lead us to tests which will enable us to choose which drug to administer to which patient. In pharmacodynamics, we have two core research strategies. The first are candidate gene studies. We look at genes which encode receptors that are anticipated to be associated with the effect of the drug. Not only receptors, but any protein that is involved in how the drug acts. These could also be transporters, and these could also be other proteins. And one looks for correlation of variation in these genes with the effect of the drug. And secondly, and this was discussed earlier in the discussion period, genome-wide association studies. Hypothesis-free approach where one essentially interrogates the entire genetic variance of the genome and looks for single nucleotide polymorphisms that are associated with the phenotype of interest, and then looks for replication in additional samples. I'm going to be presenting studies of both types. I had intended to go a little bit into the issue of pharmacokinetics and talk about the use of CYP450 and also contrast it with abacavir, but I think this was covered quite well in the previous session, so I won't do so right now. So I'll move then on to the data section of the talk and speak about RGS2 in antipsychotic-induced Parkinsonism. And we mounted a study some years ago in order to generate a sample which could tell us about pharmacogenetic aspects of antipsychotic drugs. The study was conducted in a tertiary psychiatric hospital. Patients acutely psychotic with schizophrenia were recruited. Medication was defined by the treating clinician. Patients were treated with first-generation antipsychotics or first-generations plus risperidone, and patients who received second-generation drugs were not included. Ratings of clinical state and EPS were administered at baseline and then weekly. And then we focused on a series of candidate genes which were screened by high-throughput sequenome methods. This was an open study, and there was no placebo-controlled group. We did find some very interesting findings regarding effect on response. We found an interesting gene, NEF3, associated with response, but I'm not going to focus on that today. What I do want to focus on is our results concerning antipsychotic-induced Parkinsonism. So we defined Parkinsonism as emergent Parkinsonian symptoms or worsening of existing Parkinsonian symptoms. We had 33 patients who developed symptoms and 82 who did not, and they were pretty similar in all other respects as shown on this chart. The first series of genes that we decided to look at was outside the usual suspects, not the dopamine receptors, but we were interested in post-receptor signaling. So we decided to look at RGS proteins, an interesting group of proteins which are pivotally involved in signal transduction. Essentially, what the RGS proteins do is that they lead to hydrolysis of GTP and essentially reduce the efficacy of the signal, so that if RGS function is reduced, you'll have a greater degree of signaling. If RGS function is normal or enhanced, you'll have a lesser degree of signaling. And dopamine receptors, G-protein coupled receptors in general, of which dopamine receptors are an example, are pivotally linked to the effect of RGS proteins. So we hypothesized that genetic variation in RGS proteins could be associated with the development, with the likelihood of developing antipsychotic-induced extrapyramidal symptoms, and in particular antipsychotic-induced Parkinsonism. And we looked at a panel of SNPs, and indeed, the gene which came up showing a clearly significant effect was RGS2. a gene located on chromosome 1q31. We had several SNPs in the gene which were associated, including one RS4606, which was associated after correction for multiple testing. So this was the first finding. And as I said, there were 5 out of 6 polymorphisms, and the strongest finding was for RS4606. This is a functional polymorphism. The G allele is associated with reduced expression of RGS2 protein. And patients who carry the RGS2 G allele would be expected to have enhanced dopaminergic signaling because there is less expression of RGS2, and therefore would have less susceptibility to antipsychotic-induced Parkinsonism, which is associated with blockade of dopaminergic signaling. This is the gene, which is the SNP. The gene itself is a small gene. It's only 3.24 kb, and the SNP in question is located in the 3' regulatory region. And we published this finding in 2007 in Pharmacogenetics and Genomics. The next step was to look for replication, and we were collaborating on this with Robert Smith, an investigator from NYU, who had assembled a relatively large sample of patients very well characterized and treated with antipsychotic drugs. This was not a prospective study, as was the Israeli study. This was a cross-sectional study. These were patients recruited while on treatment and very carefully assessed. Also, as opposed to the Israeli study, we included here patients who were on atypical antipsychotics. And we genotyped the same SNPs as were significant in the Israeli sample and found replication for RS4606. In other words, in the US sample, RS4606, in the RGS2 gene, the G allele was associated with reduced susceptibility to antipsychotic-induced Parkinsonism. This was true in the overall sample, and this was true in the African American sample, which made up the bulk of the Smith NYU sample. What does this mean in terms of risk? It means in the Israeli sample that carriage of the G allele reduces risk of developing antipsychotic-induced Parkinsonism approximately 3.2 times. In the US sample, 4 times. In the African American subsample, 5 times. So if you're an African American and you carry the G allele of RGS2, according to our data, you're 5 times less likely to develop antipsychotic-induced Parkinsonism if you are administered a first-generation antipsychotic drug. And this paper was published in Pharmacogenomics Journal. I'm waiting for the shares to rise, Julia. We're about 5 now. I'm confident this will be a good investment as well. And this shows it graphically. This is the risk of antipsychotic-induced Parkinsonism in the Israelis with carriers of the G allele. This is in the overall US sample, and this is in the American sample. And these are data from Semplicini, an Italian researcher who's interested in RGS2 in hypertension. RGS2 is a player on many stages, and one of them is hypertension. And Semplicini showed in fibroblasts from hypertensive patients and controls that there was a lower expression of the RGS2 in carriers of the G allele. And I remind you that the polymorphism is located in the 3' and untranslated region, so this is not an unexpected finding. So this is the RGS2 story. The G allele, which one would expect would be associated with reduced dopaminergic signaling, with reduced RGS2 availability and increased dopaminergic signaling, is indeed associated with a lesser susceptibility to antipsychotic-induced Parkinsonism. So we wanted to go from man to mouse, and we wanted to see if we could get evidence, translational evidence, in mice. We decided to go for RGS2 knockout mice, hypothesizing that one couldn't get less RGS2 expression than in a knockout mouse. And we obtained mouse which were wild type, heterozygous, or homozygous for the RGS2 knockout. And we then put them in an experiment in which we administered haloperidol chronically for several weeks and then acutely, and then subjected them to various tests of Parkinsonian features. I think I skipped over a previous slide. No, not here. The tests which we used were open field activity, catalepsy, pole test, and rotor rod. This work is still in progress, and I don't have the data on all the tests. Clearly, our hypothesis was that animals administered haloperidol, who are homozygous for the RGS2 knockout, would have the lowest level of Parkinsonian features. Heterozygous animals would have an intermediate level, and a wild type would have the least. And here is the hypothesis. And of course, RGS2 expression would be minimal or absent in the homozygous knockouts, reduced by 50% or so in the heterozygotes, and normal in the wild-type animals. And indeed, in terms of the expression, this shows the expression data, and this is as anticipated. And so were the findings for the Parkinsonian-related tests. This shows catalepsy at 2 doses, and you can see that the animals, we haven't yet had enough heterozygotes to test, and to have sufficient for statistical analysis. But looking at the homozygotes, you can see that the knockouts have significantly less catalepsy than the animals which are wild type when administered haloperidol. And the same is true for the pole test, where animals have less Parkinsonian features if they are homozygous for the knockout than if they are wild type. So what can we conclude at this stage? And I learned something from Professor Gershon yesterday. Don't say conclusion in the middle. People's hopes get up. So it's interim conclusions. RGS2 is associated with susceptibility to AIP in a prospective Israeli study and replicated in a US case control sample. Carriers of the G allele of RS4606, which is associated with reduced expression, have less predisposition to AIP. We have translational support for this finding in that genetically modified mice with lower RGS2 expression show reduced susceptibility in animal models of AIP. And one may conclude cautiously that genetic variation in RGS2 may have clinical utility as a marker for AIP susceptibility, and that carriers of the G allele may be more resistant to the side effect and therefore be better candidates to be administered typical antipsychotic drugs. The next stage of our research employed a GWAS approach, and I need to introduce the Catie study for this purpose because our data came from the Catie study. The psychiatrists in this audience will be familiar with the Catie study. For those of you who are not psychiatrists, I'll just very briefly explain what it was. It was a very large, very ambitious, multi-phase, randomized controlled study assessing the response of schizophrenia patients to antipsychotic medication. It was led by Jeff Lieberman, presently of Columbia University. It included 1,400 subjects, all diagnosed with schizophrenia. And it had several phases, but during phase 1, the patients were randomized to perfenazine, a first-generation, relatively low-potency antipsychotic drug, to olanzapine, quetiapine, risperidone, and ziprasidone. And the patients were very comprehensively assessed for clinical outcome and for adverse effects. There was a genome side, a genetic side to Catie, and Pat Sullivan and his group genotyped the sample, not all of them, 741 cases, with approximately 700,000 SNPs in the genome-wide SNP genotyping. These same patients were assessed for AIP severity with a Simpson-Angus scale. And at this point, we came in because this data is publicly available. NIH's policy was that all data from these very large-scale studies, including the genetic data, would be available to researchers all over the world. And I must say my eternal gratitude to Lior Greenbaum, my postdoc, whose idea it was to obtain this data and do a GWAS in silico, which is essentially what we did, because we obtained the genome-wide data, we obtained the clinical data, we divided the patients into cases who had a mean global SAS score of 0.3 and controls who had a mean global SAS score of 0. And we then analyzed the genome-wide data. Anna Alkali, one of my PhD students, did the analyses, and using Plink and other strategic approaches, and essentially looked for genes associated with antipsychotic-induced Parkinsonism in the Catie sample. Now, we did not have any SNPs which were genome-wide significant, but we did have 14 SNPs which were significant at p less than 10 to the minus 4. So this is the line for genome-wide significance in the so-called Manhattan plot, and the 14 SNPs are about here. This data was published in Psychopharmacology, but we went on in work which is as yet unpublished to look at the same 14 SNPs. We looked at them in a replication US sample treated with SGAs, risperidone, olanzapine, or clozapine. This is the same Smith sample in which we looked for replication of the RGS2 finding. We genotyped all 14 SNPs that were p less than 10 to the minus 4 in the GWAS. And one of these SNPs in the ZFPM2 gene, which we had not heard of before, was associated with AIP in the sample as a whole and among the African American subsample. And the C allele of ZFPM2 was protective. In other words, carriers of the C allele had a lower risk of antipsychotic-induced Parkinsonism. And this figure shows the data. These are the 14 SNPs, and this is the minus log 10 p-value. And you can see the striking significance of the ZFPM2 SNP, RS12678719. So this SNP is associated with antipsychotic-induced Parkinsonism. It came up among the 14 top SNPs in the GWAS and was supported in the US case control sample. What about ZFPM2? We know a lot less about it than we do about RGS2. As yet, we haven't done any translational studies with this gene. It's located on chromosome 8, Q23.1. It encodes a zinc finger protein. Zinc finger proteins have become very important. Several recent findings coming out of major psychiatric genetic studies have implicated zinc finger proteins. It's a widely expressed member of the FOG family of transcription factors. And what is important that it's highly expressed in brain. The data here, not from our work, but taken from the databases, shows expression in different areas of the brain. This is the expression in the nigrostriatal region, which is of particular interest to us. So, summing up that section of the talk, we have evidence from a GWAS supported by a replication study in a case control sample to suggest that ZFPM2 may be associated with antipsychotic-induced Parkinsonism. And we have two genes, RGS2 and ZFPM2, each with alleles which may be protective or may be in a linkage disequilibrium with protective alleles for antipsychotic-induced Parkinsonism. So the next step was clinically to look at the implications in terms of the potential as a diagnostic test. And certainly from the point of view of sensitivity, the potential is there. RGS2 alone has a sensitivity in the region of about 55 to 60%, which is really not clinically relevant. Odds ratios do not always translate into clinical sensitivity. With ZFPM2 alone, it goes up to about 75 to 80%, but with ZFPM2 plus RGS2, we're already exceeding 90%. In other words, we have a 90% likelihood of picking up those people who have a reduced risk for developing antipsychotic-induced Parkinsonism if we genotype them for these two variants. The flip side is the specificity. The specificity is only in the region of about 55 to 60%. What does that mean? It means that there are a lot of people who won't develop antipsychotic-induced Parkinsonism that we would not be able to pick up with this test. But it's far better than the other way around, because we can be reasonably certain that those people who we are sensitive to, and our test is sensitive to, will not develop the adverse effects. Whereas there are people whom we can't pick up, and these people, of course, are awaiting further variants. So, in summary, the RGS2 gene is associated with susceptibility to AIP in a prospective Israeli study, replicated in a case control sample from the US. It's the G allele of RS4606. We've shown this translationally. We've got another gene, ZFPM2, in which we had one SNP that was replicated, and carriers of the C allele have less predisposition to AIP. And the two SNPs together, the two variants together, predict resistance to AIP with a sensitivity that approaches clinical utility. So what are the next steps, and what are the prospects for clinical implementation? I think, first of all, from the general intention of this symposium, of this meeting, I think we have demonstrated that pharmacogenetic variables can have predictive power in the clinical context. But clearly this is not enough. So the next step is a very large scale study in which we are already planning, and which will be done with an industry partner, and which will simply seek out the truth, whether or not in a very large sample we are able to predict with the same level as we did here. This will not be a prospective study. It's far too expensive. It will again be a cross-sectional study, and a prospective study will only be justified if the results are positive. We don't mind doing the study between you and me, because even if we're wrong, we end up with a large sample of patients in whom we can look for more polymorphisms. We believe that we should expand the model by including additional genetic variables, and in particular looking at, in the model, adding into the model SNPs that are related to genes that influence availability of the drug, that is pharmacokinetic SNPs, CYP4P450 in particular. And what we plan to implement is a polygenic model that includes clinical variables as well. And we hope that we will be able to prove that prediction of individual susceptibility to antipsychotic adverse effects is feasible and reasonably close to clinical implementation. So just a word about my collaborators. Lior Greenbaum, my postdoc, and Anna Alkali are the two principal collaborators here. Tsuri Lifshitz is the postdoc in my lab who runs the animal studies. We did some of the genotyping in collaboration with people from the Weizmann Institute. Rael Strauss did the initial clinical study, and Robert Smith from NYU provided us with the replication sample. We thank NIMH for access to the Catie GWAS data, and of course we thank the Israel Science Foundation and the Israel Ministry of Science for support that enabled us to do the study. So finally, if you do come to Jerusalem to visit me, and you're certainly cordially invited, I'll take you to my lab, but that's not so interesting. I'll show you the Chagall windows at Hadassah Medical Center, a true work of art. We can take you for a swim at Ashdod Beach, where I go on the weekends. We can take you to the Temple Mount and the Western Wall. You can rub yourselves with mud at the Dead Sea. And if you really want to, you can visit Harry Potter's grave in the British Military Cemetery on Mount Scopus. Thank you.
Two questions. The first one very quickly was the RGS2 result replicated in the genome-wide association study?
No. It was not replicated, but there were not the same SNPs there. We didn't have the RS4606 there. Sullivan,
No SNPs at all within that.
we tried to do some imputing, but it's a very small gene. But the answer is it was not replicated, but we did not have the precise SNPs.
So the second question was your estimates of sensitivity and specificity were determined in the same sample that you estimated the effect, or were they determined in independent study?
No, it was estimated in the US sample.
Replications.
Yeah. The estimates for the two genes together were done in the US sample, not in a third sample. That we hope to have when we have completed the larger scale field study, and then we'll be able to get a more definitive answer.
Yeah, this is Colin. I have a question. First, I thank you very much for your talk. It's really nice and important in terms of global health. Since, especially students must be aware that the cost of the treatment of the second generation of these psychotics, the ground of these drugs are more expensive than the whole not only Africans but also Asians, Latin Americans. They cannot afford these new treatments. So if we improve the old ones, it could be very relevant for the world health population. I think this is something very remarkable. My question is, when I'm sure that you have been thinking about that. I'm thinking about Parkinson, the Parkinson disease. It's an extremely important problem in the elderly, and also we end up in this situation of drug-resistant treatment. There are people that doesn't respond well to levodopa, and this is a terrible problem because related to depression. At the end, most of them are suicide. So after you think to test, since this is a signal, the SNP is related to this signal, not to the receptor, to test this type of patient, do you think there's any background, or just this to be the idea?
No, I think that's really an excellent question. That's exactly what we plan to do. What we have hypothesized is that these genes are not Parkinson genes because they haven't come up in Parkinsonian-related genetic studies at all. But what we do think is that these genes could be modifier genes for Parkinson's. They could influence response to L-DOPA, for example. They could influence the development of we have another set of studies in which we've been looking at tardive dyskinesia. Genes which predispose to tardive dyskinesia could predispose to L-DOPA-induced dyskinesia. And in fact, we have a major grant submission under consideration at present with collaborators from the Parkinson's world with whom we plan to do this translation. The term fits in well here, to translate our findings from antipsychotic-induced Parkinsonism to patients with Parkinson's disease, specifically examining that hypothesis, that genes that influence susceptibility to antipsychotic-induced extrapyramidal symptoms may be modifier genes that influence Parkinson's disease. Not major genes, but modifier genes. So that was a pretty smart idea.
Before we close, Dr. Wasilio would like to make a statement.
I had made an announcement about the dinner for those who are registered in the Boots course earlier, and I just would like to clarify that there is, at 6:30 actually, the room will be open for drinks. So there will be drinks at 6:30, and the dinner is at 7 for those who have registered for the Boots course at the University House. Thank you. It's the University House, and with inside the University House, it's the Union Room. Thank you. There was one more question here.
Slightly outside your territory, I work with medical education in local students. We find a lot of people who've been on antipsychotic drugs are becoming very overweight and then predisposed to diabetes.
Can I hear the question?
Yeah, I'll repeat it. Yeah, the question was about patients who receive antipsychotic drugs and become overweight and develop the risk of diabetes. That is, very well recognized adverse effect of the second generation drugs. And there are a lot of studies which are attempting to look for markers which will allow prediction of which patients are more susceptible to these particular adverse effects. But that's another reason that makes it more logical makes it more rational to look for tests that will allow us to administer first-generation drugs. Because if you have a patient who's got olanzapine and has put on weight significantly and developed and is pre-diabetic, you would like to be able to give him a first-generation drug. And if you can do so with reasonable confidence that he's not going to develop antipsychotic-induced Parkinsonism or tardive dyskinesia in addition to the diabetes that he already has, then I think it would be pretty good. So we personally, from our work, don't have findings which are relevant, but certainly there are many groups in the world that are looking at this issue very intensively. Well, you mentioned amisulpride. Amisulpride is a very interesting drug because it's kind of an old first-generation drug which has second-generation properties, and it's a very interesting drug. Ziprasidone also induces less weight gain, but there are questions about its potency, about its efficacy. Clearly, there are greater and lesser sinners in terms of inducing the metabolic effects, as there are greater and lesser sinners in terms of inducing extrapyramidal syndromes. But overall, there is a very great degree of individual responsiveness here, which can be addressed from the pharmacogenetic perspective if one has the tests.